Thank you so much for having me. Today I'm going to talk a bit about a very specific kind of data that we've been working on in my group for some time to understand how diseases spread. And then I'm going to really focus on how we tried to make it useful during COVID-19 and some of the lessons learned from that effort. So throughout the pandemic, and actually more generally for many kinds of infectious diseases, one of the hardest things about the pandemic has been understanding how many cases there are at any given time in any given population. And I think that this is one of two reasons that some of the modeling efforts have had mixed results in the context of decision making. So if you think about COVID-19 here, people get infected, they don't become symptomatic for about 5 days, and they're infecting people even before they're symptomatic. They may or may not get tested depending on the severity of their symptoms and their access to health facilities. And then there may be delay in the turnaround of test times. And following that, there could be hospitalization and even deaths. So in terms of epidemiological data, we really only have clinical confirmed cases in most settings to understand how many cases there are in a population, and possibly hospitalization rates and deaths. But what we really want to know about is transmission. So how is transmission happening in real time? And some of the data sets that I'm going to talk about can provide us insights into that. So you may have heard of SIR models and the reproduction number. We've been talking about a lot about that. And really R0, or the basic reproduction number, is a way to explain and describe the growth rate of a disease in a population. Now, the components of this basic reproduction number come down to three basic parameters. The first is the probability of infection given contact, so the contagiousness of a disease. The second is how long people are infectious for, and that's obviously going to determine how many onward infections they can produce. And the third is the number of potentially infectious contacts people have per unit time. And these are the parameters that determine the basic reproduction number. And of course, they lead directly to some of the non-pharmaceutical interventions that we have implemented in the context of COVID-19. So masks reduce the contagiousness of people in contact with each other. We try to shorten the duration that people are infectious by asking them to quarantine if they have symptoms and to do testing and tracing and so on. And lastly, all of the social distancing and lockdown policies that have happened over the last year and a half have been related to this contact rate. So if they've been designed to reduce the potentially infectious contact rate in the population. The first two parameters have biological aspects to them, and although there is variation around them, to some extent they don't vary between populations. The contacts per unit time are by definition a population-specific parameter, so it's very context dependent. And what that means is that depending on the population involved and how they respond to the epidemic, the contact rate is something that is going to vary over time and be different depending on the population in question. So what that means is that the reproduction number is by definition a context-specific parameter. There is no single reproduction number for COVID-19. So here we look at R0 estimates across the US, for example, and it varies depending on whether it's an urban setting or a rural setting and how the population is behaving. So in general, I think it's important to remember that for any mathematical model of the epidemiology of this disease, the case counts are generally all wrong. So we have to either adjust them or understand the context in which the data are being reported, and that the contact rates are highly context specific. And that makes it hard to produce generalizable models that are useful for specific settings in the context of specific policies. Two aspects of the contact rate are important here, and I'm going to talk about how we parameterize them using new data streams. The first is contact rates within populations. So what kind of mixing is going on within a particular group of people? And then there are contact rates between populations. So this is thinking about the spread of disease on a larger spatial scale and between countries or between towns. And I think this contact rate is important at different parts of the epidemic in different ways. So in the beginning of an epidemic, when we have limited community transmission, we want to know about between population contacts because we want to understand the risk of importation events and where those infections might be coming from. as we get community transmission and the implementation of non-pharmaceutical interventions, we want to know whether those interventions are working to reduce the contact rate, has clustering increased or decreased, what's happening with travel. When we take away the interventions, has travel resumed? And then at the tail end, so as cases have reduced, we want to keep track in our surveillance systems of potential imported cases, new variants coming in, and whether we think that people are continuing to social distance or not. So until the last, I would say, 10, 15 years, there were really limited sources of information about both within population contact rates as well as between population contacts and connectivity between places that drive the spatial spread of disease. So in the past, we relied on things like travel history surveys, census data, cross-border surveys and things like that. And here, this graph is kind of divided on the x-axis into the spatial dimension from neighborhood all the way up to international, and the y-axis is the temporal scale, so very rapid timescales all the way up to long-term timescales. And of course, for an epidemic, we need this information potentially in granular ways, in neighborhood levels, all the way up to international, and really on short timescales. So we want it in real time. And now we have all these new data sources, primarily deriving from the use of mobile phones in populations, which are now ubiquitous around the world, even in quite remote settings. And so a combination of these data sets can now be used to parameterize the contact rates of populations within them, and as well as connectivity and travel between them. So this has really changed how infectious disease epidemiologists think about these contact rates, measuring them, monitoring them, and then using them in mathematical models. Before 2020, the way that we did this, and I've been working with mobile phone data for a long time, particularly with partners at Telenor Group, who have operators in business units in South and Southeast Asia, is that you'd have this partnership. So academics would work with industry partners to access data and simultaneously be working with public health agencies to help translate the data into maps or other estimates that they needed. And it was an incredibly lengthy process to convert all of this rich but generally opaque data streams into something that was actionable. It required a huge amount of regulatory approval, data use agreements, review boards. On the national level, multiple ministries needed to be involved. There was a lot of ethical approval, which is correct, because this data, if not aggregated appropriately, could lead to loss of privacy among subscribers, and that's something we don't want to do. What's happened in the last year and a half is that some of these data sets have become available at scale and much more easily accessible over very short timescales. So at the beginning of the pandemic, we had companies from Cubic to Apple and Google producing aggregate mobility data in real time and putting out dashboards about how people's movement was changing locally. The problem here is that although industry has this valuable data about human mobility, and policymakers do need to make decisions based on data, generally there's just not any capacity at the decision-making level to use this data in a way that's really clearly related to the things that they need to do in their policy. So there's this gap. So there are these dashboards, but for the most part, most policymakers, I would say, didn't know what to do with them and didn't really know how to use them to make sense of their data. So last year, together with Andrew Schroeder, who's at Direct Relief, and Sajid Balsari at Harvard, we put together this COVID-19 mobility data network, where we brought together a bunch of academics and partnered them with specific policymakers. We brokered the data sharing agreements. We worked with Facebook a lot for this. And then we provided daily reports to policymakers for a specific context, working with them iteratively to address their specific needs. And I think that was something that worked well, because there was a human in the loop that had technical abilities, who understood what epidemiological models needed and understood the needs of the policymakers, and then responded to feedback. So it wasn't an automated process. It was actually a network and human-driven approach to use this data sensibly. And I'm going to present some of the data that were put together by my team, specifically Nishant Kishore, who's my graduate student. So of course, some of the stuff that you can do with this data is obvious, right? So you can look at long distance travel. Here, we're just looking at long distance travel in the US before and after the big lockdown in the middle of March of last year. And you're looking at the average daily transitions between locations. And you can see that the lockdowns had a major effect on long distance travel that's quantifiable. So we can make quantitative statements about how many people were traveling between different locations. We also used it to look at where aggregation was happening anomalously, so over and above normal, for example, in Memorial Day, so that we could help policymakers understand where they might expect outbreaks or outbreaks to be emanating from in the context of some of these gatherings that they were struggling to control and understand. The other thing that's happened, and I think this is an interesting and a near universal finding, and of course has happened throughout history in the context of epidemics, is that we've seen an emptying out of urban centers. So here you're looking at the change in nighttime Facebook population. So we think this is basically residents who are normally at home in the night. And then we look at the fraction that have left and during the nighttime over the course of the beginning of the pandemic. The vertical line there is the lockdown. And you can see that we had a massive loss of populations around the US from our urban centers. This happened in heterogeneous ways. So this is a map of New York looking at the percent change of nighttime users. And you can see that Manhattan really emptied out in the month or so following the lockdown, whereas the neighborhoods further out from Manhattan, people didn't leave. The population stayed relatively stable. And in fact, this urban rural migration caused by lockdowns has been found all over the world. Here you're looking at, again, Facebook data. So we're again looking at migration patterns using Facebook mobility data, but we've stratified our populations by urban and rural using nightlight information from satellites. So the yellow lines and the yellow dots are urban populations with high nightlight, and the further blue you go, so the dark blue lines are rural populations. And then we're looking at the shift in population density. And so what you can see in France, India, and Spain, to a varying degree, is a shift where people have left urban centers and they've gone to rural areas when lockdowns happen. That has really important implications for the spread of disease. And so when we model this out, we can see that in some cases, lockdowns actually lead to an increase in disease in rural populations that wouldn't otherwise have received incoming visitors from the city if it was normal baseline travel behavior. And so that's interesting for like messaging for lockdowns and thinking about the efficacy of lockdown interventions. Of course, in each of these settings, the kinds of people that are traveling are very different. So in Manhattan, it was largely wealthier neighborhoods where people left, presumably to go to rural houses or to stay with family. In places like India, and we saw this in Bangladesh as well, the people leaving the city were often lower socioeconomic status, and they were leaving when jobs closed and things like that. So the social context is very important to understanding what kind of public health intervention you need to modify when thinking about these lockdowns. Something that we've seen in cities around the world is that the mobility changes due to lockdowns and social distancing interventions have been responded to along lines of socioeconomic status. So everywhere, we've seen that people in poor neighborhoods are not only burdened by COVID-19 more, but they also have not been able to lock down as much because they are essential workers, because they can't afford to work, they can't work from home. So this is a study we did in Chile, in Santiago. And what you see here is the changing mobility patterns on the y-axis by date on the x-axis, and the lines are colored by the socioeconomic status of the neighborhood. And so the green lines are the richer neighborhoods and the darker red lines are the poorer neighborhoods. And you can see that the mobility patterns in the poorer neighborhoods are consistently higher. So essentially people in poor neighborhoods had to keep moving around. They were not able to lock down. And as a result, in that setting, we saw much higher morbidity and mortality, and we were able to link this with socioeconomic status and access to healthcare. That is not limited to the global south. This study that we did looking at seroprevalence, actually it was prevalence, not seroprevalence. So this was active PCR infections in pregnant women coming to hospital around New York. And what you can see is that the percent of infected women delivering at hospitals was very variable across the city. The reason that pregnant women are a useful sample is because, unlike confirmed clinical cases, they're much more random and therefore much more representative of what's happening. And if you look at commuting patterns using this data, so this is mobility out of your neighborhood in the morning, back in the evening, you can see that the estimated prevalence of SARS-CoV-2, and this was back in spring of last year in New York, it was very well correlated with commuting. So again, neighborhoods that had to continue to commute because they were essential workers or they were unable to work from home were the ones that had the highest burden of disease. So it all makes sense, but now this type of data is allowing us a mechanistic link between observed patterns of cases and the ways the contact rates might be affected. So I think there's an open question now. There's more access to this kind of mobility data. And that's, I think, a good thing as long as we can figure out the regulatory and privacy issues that are there, which is an important point I'm going to come to at the end. But I think this data has been embraced wholeheartedly by modelers, not just from EPI, but from economics and physics and so on. But I think there's a question about the extent to which this data can be used to understand transmission. The contact rates that we can measure using mobile phones are not necessarily the face-to-face interactions that people that spread the disease between individuals. And so we wanted to know the extent to which transmission was actually linked to some of these mobility proxies from mobile phones. So we looked across multiple counties. This was work done with Nick Menzies at Harvard and Ted Cohen at Yale. And what you're looking at are all the counties that we had mobility data for, and we used an epidemiological method to back calculate from deaths and hospitalizations what transmission must have been, mainly because you can't trust the confirmed case counts. And we stratified by urban to rural with our counties. So here you're just looking at where the data is coming from. And again, you can see that the urban ones are in darker green and the rural counties are in paler green. So what we found was that the correlation between our mobility derived estimates of what we think should be happening with the contact rates and transmission are quite well correlated with actual epidemiological case counts and what we think is going on with the data in urban centers. So here, don't worry too much about the colors of these dots, just to note that there is a negative relationship as we get more rural. So essentially what's happening is that the strong relationship between mobility proxies and transmission reduces as you go to a more rural setting. And that's partly probably due to population density changes. So the epidemiology itself is changing and there's going to be more stochasticity in the low population areas, but also because the mobility data is going to degrade. It's going to be less representative and have less good coverage in rural areas too. So the signal in the data is also degrading. And that's important, I think, as we start to apply these data sets to epidemiological models. We can't use these uncritically, and we need a really systematic way of dealing with uncertainty and representativeness. Right, so here in the urban centers, we have in some cases very good correlation between these data and not so in the rural areas. Okay, so the other thing that happens is over time, the signal degrades. The correlation between mobility proxies and epidemiological case counts degrades. So here, what you're looking at is different time chunks in the epidemic, which you see in these with these blobs of data points. And then what we're plotting here is that correlation on a county level between the epidemiological measure of transmission and our mobility proxies. So they're very well correlated at the beginning of the epidemic, as you can see. And then as time goes on, by about June, there's almost no predictive value in the mobility data. And that's because many other things are happening. So at the start of an outbreak, like things like migration routes are really strongly predictive of where the disease is going next. And the policies that we're implementing, like the lockdown policies, are going to strongly impact contact rates in a deterministic way. As the epidemic progresses, that becomes less true as mask policies come into effect, as some portion of the population is no longer susceptible, and so on. So again, this isn't to say that it's not a useful approach for predictive purposes, it's just that it has to be nuanced in terms of how you use it. So we wrote a paper in Lancet Digital Health last summer, pointing out some of these issues. So that the data, the representativeness of these data sets is a big issue. And at the moment, data providers do not usually provide any kind of representativeness information or breakdown by demographic features. They can, and in some cases, they're moving towards that, but there's a balance with privacy. So I think it's really important that uncertainty is something that is quantified and reported in a standardized way. Baselines have also been an issue, and we can talk about that if people are interested. And then the data sharing frameworks is very variable by country, by data provider, and by data type. And I think that we really have to figure out a strong regulatory framework and some standardized data sharing processes so that this can be used safely for public health, which I believe it should be. So I'm just going to end by talking about some of the failures during COVID-19 from my perspective, my narrow perspective. So in academic science, we've been working on some of these methods for a long time. And we write papers that say this is useful for policy, it could be used during outbreaks and so on. We've published dozens of papers like that. Decision makers during COVID-19 were overwhelmed with data, and they didn't have the capacity in many cases to actually make sense of all the data that they had available to them. So I think that there's this really critical gap. The technical capacity in academia and the technical and methodological basis for what we can do now for surveillance to help policymakers is huge. But that translation hasn't happened because there's this kind of capacity gap, and the tools that we develop in academia aren't necessarily optimal for policymaking. So when you're in an epidemic, you need very specific and quite urgent results. You need information to make decisions on. In academia, we can get very fancy with our methods, but there's not necessarily the same specificity and urgency requirements. In fact, sometimes those are disincentivized, and the way that academia works doesn't produce data, doesn't produce results in that framework. So I think this is a big problem. And what we try to do is kind of create a distributed network of expertise that could do some of this translational work. But ultimately, governments and health agencies need to invest in sufficient technical capacity that they can absorb some of the new methods. And similarly, academics need to be incentivized to actually do decision-making and policy relevant work. So we've built this platform called Crisis Ready, and I described it a bit before, but essentially what we're trying to do is work with partners like the World Bank and GFRR to develop regulatory frameworks and standardized protocols for data sharing. And then we're building a network of partners around the world that can work with local policymakers to help them make context-specific decisions using new data streams. And I think without that human connection, we're not going to move forward with the surveillance systems in a way that will prevent the next pandemic. So I'm going to end a few minutes early, but to summarize, you really need domain area expertise, especially in the context of epidemiological modeling. I think there was a lot of, during the pandemic, there was a lot of situations where people that didn't have expertise jumping in to try to be helpful, but making kind of rookie errors because they hadn't worked with epidemiological data before and didn't understand some of the constraints. We really need a globally distributed system for translation. So not a single model where we automate everything and then apply it everywhere, not a million dashboards that aren't helpful. And I hope I don't offend anyone. I don't think we need more management consultants jumping in to try to do this translational work. We actually need distributed capacity. And I think that's a major global health gap right now. And we have to think really hard about how we educate our global health leaders, how we have academia interact with policymakers on a local scale, and what that means for the funding environment. Lastly, I would just say that these data are really valuable. Before them, epidemiologists were really in the dark about what was happening with mobility and migration, especially in real time on the timescales of epidemics. And that really constrained what kinds of predictions could be made and what kinds of targeted interventions were possible. So they should be used for public health. Right now, I think the regulatory frameworks are still lacking. And what that means is that we're either risking misuse of the data, or we're going to miss the opportunity to make use of it in the best way, because people will become scared and then the data won't be used at all for privacy reasons. So we're in a very interesting sort of transitional time for this kind of approach and for the people working on this data. And it will be interesting to see what happens next. And I hope that we move towards a rational, scientific use of these data streams to control and contain infectious diseases. So I'll just end by thanking my lab. They are wonderful, and they do the heavy lifting on all this stuff. And then Crisis Ready is a large team effort, and some of our funders are there. Thank you.
Thank you, Caroline. I mean, for a very inspiring and wonderful presentation. I mean, I think we really learned a lot in this talk. And yeah, we have now a few minutes for questions, and the first one comes from the audience, we got the question is, do you have any recommendation or experience on how to to address data reliability? Are multi-level models or Bayesian approaches a good idea?
So in general, I'm a fan of Bayesian approaches. My concern with this data is mainly that we haven't put it through the rigorous quantitative work that we would for other data sets, for example. And so because the data providers very rarely release raw data, there hasn't been an opportunity for the academic community to really kind of break this down quantitatively, figure out how to measure uncertainty and biases, and do that in a way that's systematic. So my concern about multi-level models, for example, is that we're going to plug it in somewhere and we don't understand the uncertainty in the raw data, in the data itself well enough to be able to robustly do that. And then we're going to, at some point, it's going to fail. So that's my concern there. I think the first step is kind of coming up with standardized data protocols. We're working on differential privacy approaches that are very transparent, that companies could apply to their data so that we all at least know how they've come up with their mobility estimates, right? Because at the moment it's very opaque and you're not actually sure what the numbers translate to. So I think that before we kind of go more sophisticated, we need to do some of the basic stuff that we would normally do for any data that we were going to use for public health. But because it's from industry, because there's been this enthusiasm for its use rapidly, it maybe hasn't undergone the rigorous kind of first step that we would need before we get more sophisticated.
Well, yeah, thank you. Very, very clear. And it comes to my mind. Oh yeah, I mean, there's another question. First, I will go with the questions from the audience. On the academic side, the system seemed built pushing us towards competing with our colleagues into making our paper fast, rather than all participating to a real large-scale collaborative effort. So do you have in mind any design to promote open, non-competitive collaborations in this area?
I think this is a really important and hard problem. Academics are incentivized in the wrong way for the future of science. The best science now is interdisciplinary and collaborative, and a lot is possible. And the people in science that are trying to be collaborative are doing it in spite of the incentives of their job, right? So I think that there are ways to think about doing this differently. At the moment, we measure outputs that are tangential to what we're trying to achieve. So we measure academic achievement in papers and grants and things like that, when we should be measuring impact. And I think that there are ways that we can have a better metric for impact. and a better metric for collaborative work. And it's about institutional change. The problem is that academic institutions are notoriously glacial in how they move these processes forward. I do think that there are examples of institutional arrangements that work quite well for this. Public Health England, in Norway, they have like a public health research institute. Sometimes you can shift the incentives with these kind of intermediary institutions that are by definition applied. So I think that's a good thing. There are some competition models where teams can all be incentivized. I just think that it's going to be slow to get away from this publishing model where first author, last author, all of these meaningless, relatively meaningless proxies for merit are used by the academic institutions, and they just have to catch up. Honestly, I think that if they don't catch up, everybody will start inventing new ways to do science, whether that's working in Google or doing research in an industry research environment. That might start happening, and we're seeing it in our younger generation of scientists. So I think this is something that academia has to fix quickly.
Yeah, the next question from another attendee is, thanks for the great presentation. How much, so the question is about what is the coverage of this type of data, and how does the low coverage still lead to valuable insights?
Yeah, the coverage is very variable depending on the data type, on the country, and on the region within the country. And it's also very variable with respect to demographic groups, right? So we're not capturing children, for example, with these large passive mobile phone data sets, clearly. So coverage is variable. I think the data is very useful for some things, and we need to be very clear about the use cases. So relative mobility patterns between cities, we can do a great job of that. Even within a city, we can do a relatively good job of neighborhood activity and so on, even though you wouldn't use the actual numbers, right? Because you would use relative routes of travel and things like that, because we understand that it's not entirely representative, but it's hopefully good enough. In terms of more broad coverage, mobile phone mobile operators have better coverage in terms of dumb phones and in low income settings and things like that, but they're still constrained by where they have towers. So then market share becomes important. All of these are quite nuanced considerations, and I think there are some settings where we have to just accept that the data is not sufficient to answer the question involved. So for example, a couple of years ago, there was a cyclone going to hit Mozambique, and we wanted to understand mobility patterns so that we could plan cholera vaccination more effectively. But there was Facebook data, but it was so sparse that we decided not to use it because it simply wasn't sufficient to be able to have any kind of robust insight. So there are definitely use cases and settings where it won't be useful for the question you want to answer.
Thank you. A question I have about the scheme that you propose, so the green space, empty space that needs to connect the academic and the policy making. I wonder, do you think there's the need of new professional profiles there, of some really new jobs in a sense, or can it be like can we think of a new way of studying epidemiology, of training, let's say, training new epidemiologists that could fill that gap of connections, or
I think both. I think both. So if you think about it, it was only relatively recently that departments of health had chief information officers, and that emerged with recognition that there was like data management and so on was important to your sort of public health response. And I think we do need a new layer of individuals who can speak both languages, right? They are more technically trained, but they understand policy needs for a specific context. I think that's really important. We need those people, and they don't exist. And maybe we call it, I don't know what we call them, but we do need a new layer of people. And to support them, we need a new curriculum format for people going into public health. Certainly at Harvard, I think our MPH program, for example, is not adequate currently to deal with all of the possibilities for trying to contain outbreaks. And, you know, academic science zooms off in its own direction. And sometimes what's happening in public health doesn't keep up. And what that means is that there's an increasing gap between what's possible and what's practiced. And we need to really think about that gap because it's going to have significant repercussions when another pandemic happens.